Cholinergic blocking drugs. These are sometimes referred to as cholinergic antagonists, and these drugs form the subject of Chapter 8. Where are the various types of cholinergic receptors? As we've been spending some time on the autonomic nervous system, we know that there are many muscarinic receptors of 3 major types throughout the parasympathetic nervous system. Things such as the M3 receptor, which we see in the eye, which when stimulated by acetylcholine causes the iris to contract away from the cornea, opening up the angle. So in a chapter on cholinergic antagonists, a drug that can prevent that from happening will cause the angle to get smaller and will cause the pupil to get larger. So when you look at the various receptors on this next couple of slides, in terms of where they are, these slides are just again written in a way to remind us of what happens when said receptor is stimulated. Right? Just as we saw in Table 6-3 of our textbook, what happens when these receptors are stimulated. And so here we are in a chapter where we're talking about blockers of said receptors. And so if we understand what happens when they're stimulated, we can predict what happens when they're blocked. So the drugs in this chapter, rather than causing meiosis, are going to cause mydriasis. Rather than causing the pacing and the contractility of the heart to go down, these are going to prevent that from happening, so the heart rate will stay high, the contractility will stay high, and so on. If we look at the lung, inhibiting this M3 receptor will prevent contraction, So again, this is written in a way to describe what happens when the receptor is stimulated. But in Chapter 8, chapter we're going to talk about now, we're looking at what happens when the receptor is blocked. So blocking M3 receptor will prevent contraction of the bronchi, will prevent secretions from increasing. And so a drug like ipratropium or tiotropium, which are muscarinic blocking drugs, have utility in respiratory disease because they help the patient breathe better by preventing bronchoconstriction and by preventing secretions that would otherwise obstruct flow of air. Okay, so I'm not going to read through every tissue and every receptor because these are things that hopefully we've been looking at since first encountering the table in Chapter 6. But the drugs we're talking about in this chapter are useful in preventing bronchoconstriction. They're useful in preventing urination. And so preventing urination is something that you wouldn't want to do in a regular, otherwise healthy patient, but you would want to prevent urination in, for example, a child who's wetting their bed, or, for example, a senior patient who has lost bladder control or developed incontinence, or in some cases we say have an overactive bladder. Does that make sense? So hopefully it does. You want to know what the receptor normally is doing when it's stimulated, and then what happens when you block it. Okay, so again here we see normally stimulating the M3 receptors on endothelial cells cause a weak vasodilation of blood vessels. We see that stimulating M3 receptors helps the release of sweat, thermoregulatory function, saliva, tears, nasal secretions. And so antimuscarinics have a drying effect on all of these things. So when we get to this idea of cholinergic blockers, Oftentimes they're referred to as parasympatholytic, which means to prevent or to lyse or to break a parasympathetic response. Another common term is antimuscarinic. But if you just for a moment drop down to the bottom of this slide, you'll see that we don't just affect, or parasympatholytic doesn't describe all of the effects of colonoceptor blockers, because we know there are acetylcholine receptors in the ganglia of both sympa and parasympathetically innervated tissues. And we know that there are colonoceptors in skeletal muscles. So there are two other classes of colonoceptor blockers that will be the subject of the next lecture, which are ganglionic blockers and skeletal muscle blockers. For the present moment, we're going to focus in on antimuscarinics, such as atropine or scopolamine, which are actually very related in structure. And these two compounds, originally identified from plants, are referred to as belladonna alkaloids. And again, the phrase belladonna is Italian for beautiful woman. And so back many centuries ago, when people started to understand various pharmacologic activities of plants, it was noted that the belladonna plant, if you formed an extract of it, could cause pupil dilation. And so this type of extract was used for cosmetic purposes. Years and years ago, dilated dark pupils were considered to be fashionable or cosmetically attractive. So that's where this name belladonna comes from. Okay, and atropine and scopolamine are the prototypes in this class. And a classic description of atropine poisoning, which we understand well because it's been around for centuries, and like all things, it's been abused or taken too much. And so we know the classic description of atropine poisoning involves skin being warm and red as a beet. Why is that? Because the sweat glands are being blocked. The person is blind as a bat. Why is that? Because their vision is being disrupted due to pupil dilation. Right? We say that their accommodation for near vision goes down. So things that are close by become blurry. The patient becomes dry as a bone. Why is that? Because all of the secretions that we just explained on the prior slide are being blocked. Right? Sweat gland, salivary gland, and others are being inhibited. Mad as a Hatter refers to the fact that these drugs do cross into the central nervous system and can cause symptoms ranging from kind of agitation all the way up through kind of delirious responses. And so an overdose of a belladonna alkaloid is a dangerous thing, particularly because, as you see here, it can be lethal. A patient could die from it. And so again, due to effects not just in the autonomic nervous system, but also in the central nervous system. And so again, we look at this slide, ganglionic blockers, skeletal muscle blockers, will be discussed in a little while in a separate PowerPoint. Now, antimuscarinic drugs have clinical utility in ophthalmology. They're used to dilate pupils for eye exams. Some of them have anesthetic properties. Some of them have amnestic properties as well, so that an uncomfortable surgical procedure can now become one that's not really remembered clearly. They have clinical utility in cardiology, particularly in the treatment of a type of slow arrhythmia called bradycardia. They have utility in GI diseases, particularly in conditions where you have hypermotility of the gut. Severe diarrhea, for example, which is not going to be due to bacterial infection, because obviously these are not antibiotics that would kill a bacteria, but if the cause of GI distress is bacterial infection, then antibiotic will be the better drug to use. But for a non-infectious cause of highly active intestine, these will decrease motility, right? These types of antimuscarinics. We see in the CNS, particularly some antimuscarinic compounds used in Parkinson's disease. While we don't really discuss that disease state in the present class, you'll see such drugs again when you talk about Parkinson's disease in future courses. But I'd like to point out that scopolamine is a very effective drug for motion sickness. And it's important to note that in that setting, scopolamine is dispensed as a patch that you put behind your ear, right? And that is going to have efficacy in the ear to help you maintain balance when you're on a vessel, like a cruise ship or a boat, that may be challenging your vestibular senses and your sense of balance. Right? So you'll see scopolamine used to treat motion sickness. It's most effective, however, if administered before the motion begins. And last but not least, antimuscarinics such as atropine are useful in the treatment of poisoning by acetylcholinesterase inhibitors. So you may recall from the prior chapter that a drug like tupam, also known as pralidoxime, is useful to regenerate the enzyme acetylcholinesterase so long as the enzyme hasn't yet aged with the organophosphate, right? So tupam is a nice acetylcholinesterase regenerator, but a drug like atropine will be useful in blocking symptoms caused by muscarinic excess. So the mechanism of action of these drugs typically involves competitive block of muscarinic receptor. Generally speaking, if an effect caused by a drug can be blocked by atropine, that's usually going to be first-line evidence that an effect is being mediated by muscarinic receptor. Right, so if you see some kind of response to a drug that can be blocked by atropine, that's pretty conclusive evidence that the response is due to muscarinic receptor activation. In this world of antimuscarinics, the natural alkaloids we've been discussing thus far are atropine and scopolamine, and these are considered classical antimuscarinic compounds. And there are some slight potency differences between the two. Scopolamine is more potent for its CNS effects, its depressant action, than atropine is, and has more salivary effect, more effect on bronchial secretions and on sweat than atropine. Atropine's effects are more potent in the heart, in the GI tract, in the bronchial muscle, and they're more prolonged than scopolamine's, and we'll even see that in a moment when we talk about the eye. But higher doses of either will produce similar effects. Okay, so what I'm trying to say in this information is that there are potency differences, but in terms of ultimate pharmacodynamic effects, they're pretty similar. So if we were to look at atropine and look at its physiological action, we see that it blocks cholinergic action, for example, in the eye, which would lead to mydriasis or pupil dilation. And that pupil dilation has a consequence. It causes something called cycloplegia, which is a condition where a patient is unable to focus for things that are close. Okay, unable to focus for things that are close. This is exactly and precisely why, if you go for an eye exam that involves dilating your pupil, that you not drive home immediately after. For such behavior would be risky, because it's difficult to see things crisply and clearly when your pupils have been dilated. In addition, a drug like atropine can be dangerous in people with glaucoma because why? Atropine shuts off the angle, right, between the iris and the cornea. And so outflow of aqueous humor through the canal of Schlemm is obstructed. And so fluid can persist in the eye, and that's something to be concerned about, particularly in glaucoma patients. So really, such a drug like atropine should be avoided at all costs in someone with glaucoma. In fact, individuals who are 40 years or older tend to already have a decreased ability to accommodate, and so an eye doctor may not even need a drug to perform their eye exam. They might be able to just see back into the structures of the eye without dilating the pupil in these older patients. Okay, so prediction of physiological activity of scopolamine is obviously going to be similar, as well as other antimuscarinics that will block this M3 receptor in the eye. So, getting back to its physiological action, we see atropine as an antispasmodic agent. It's able to reduce the peristalsis of the GI tract and its activity, so it reduces the motility. It's not particularly effective at reducing acid secretion by the stomach. There is an antimuscarinic drug that's been used for that purpose. It's an M1 selective blocker. M1 selective blocker called pirenzepine, which hasn't really been used in the U.S. To reduce acid production in the stomach. But you may see pirenzepine in other countries like Europe or Japan, for example. So what's the big deal between pirenzepine and atropine? Pirenzepine is a M1 selective blocker, while atropine is a non-selective muscarinic blocker. Okay, but again, in terms of acid reduction, we don't really use antimuscarinics for that purpose. There are plenty of other drugs like proton pump inhibitors, for example, that are used to reduce acidity, but not atropine. However, atropine is used to reduce gastric motility, and we already mentioned it's useful in the treatment of non-infectious causes of diarrhea. In addition to effects in calming the gut, atropine can reduce the motility of the bladder, and it is still occasionally used in enuresis. Enuresis is a situation where there is involuntary urination, an overactive bladder, which you particularly see among children. But there's another way to deal with enuresis that involves not M3 but rather alpha receptor. And if we think to a picture of the bladder for a moment, if we could picture that in our mind, we know that the bladder is made up of mostly smooth muscle that can contract, but there's also two sphincters, the internal and the external sphincter, and those sphincters need to be relaxed during urination, and so if they are stimulated, the sphincters close. Okay, and so it's less likely to have a urination. So there are certain alpha agonists that are useful in closing the sphincter as well. So there's two ways to try to prevent enuresis. One is by using an antimuscarinic compound. Another way would be to use an alpha agonist. Okay, but alpha agonists do have their own problems as well, and not the least of which is the potential to increase systemic blood pressure. In terms of secretions, atropine blocks the salivary glands, and it produces a drying effect on the oral mucous membranes, which we call xerostomia, lack of saliva. The salivary glands are exquisitely sensitive to atropine and scopolamine and other antimuscarinic drugs. This is why if you look at package inserts for many drugs, you often see dry mouth as a potential adverse effect. Well, if you see dry mouth as a potential adverse effect, it suggests that the drug has antimuscarinic properties, right, as adverse or off-target effects. So, yes, it's true the drug is drying, and sometimes that's useful. Sometimes it's used as an anti-secretory agent to block secretions in the upper and lower respiratory tracts prior to surgery. Okay, but its mechanism involves shutting down the glands, right? Shutting down the contraction and the release of glandular content. If we look at cardiovascular effects of a drug like atropine, we block the vasodilation that is happening in response to endothelial cells that would otherwise be releasing EDRF, or nitric oxide, that would diffuse into the smooth muscle and relax it. Okay, so that's normally what would happen, but an antimuscarinic drug blocks that. Moreover, in the respiratory system, antimuscarinics reduce vagal influence. So we see some bronchodilation and reduction of secretions. Of course, the beta-adrenergic agonist is more useful because they promote bona fide bronchodilation. The antimuscarinics just prevent bronchoconstriction. I don't know if you see the difference, but the antimuscarinics prevent bronchoconstriction, while the beta agonists actually stimulate bronchodilation. And so, again, we see antimuscarinics used prior to inhalational anesthetics to reduce secretions and laryngospasms. Now, in the eye, the constriction of the eye depends upon muscarinic receptors. What happens when we block that effect? Well, we get unopposed sympathetic nervous system activation. We also see that accommodation, or the ability to focus for things that are close or near, is also under the control of muscarinic receptors. And so what happens when we block accommodation? Things become more fuzzy. Lastly, secretions are under the control of muscarinic receptors. So what happens when we block that? Well, if we block the muscarinic receptor, then the iris is not contracting, not getting closer to, getting away from the cornea, opening up the angle. That's not happening, right? And so we don't want to block that effect. We want to increase outflow. So in the eye, we see the M3 receptor in the ciliary body that, when stimulated, will contract and cause the pupils to be tiny. But an antimuscarinic blocks that, and so the pupils are large. Okay? By blocking that contraction and by narrowing the angle, right, the production of aqueous humor that's being made by the ciliary epithelial cells, well, that aqueous humor is not exiting as quickly, and so it can start to accumulate. Right, so when you think antimuscarinic in the eye, think of has potential to increase intraocular pressure. If we were to look at this graph, on the y-axis we see accommodation or pupil diameter, and on the x-axis we see time after administration of scopolamine. And what you can see in this graph is that after administration of scopolamine, the pupil diameter increases, right? The dashed line, it increases, while the ability to accommodate immediately decreases. And if you're looking here at scopolamine and you're following the x-axis, this pupil dilation can last 90 minutes or 1 day or 2 days or even 4 days. And usually it might take even up to 6 to 7 days for scopolamine to completely wear off in the eye. And is that exactly something that you're interested in achieving? If you go for an eye exam, do you want your eyes to be dilated for multiple days, or would you rather just have them dilated for 1 day or part of a day? Okay, so you might say, well, why then would we use scopolamine? And the answer is, well, it's not often used anymore for for eye exams. There are drugs that have been developed which are shorter with respect to the duration of action. But I want you to be able to look at this graph and kind of see how pupil diameter and accommodation are inversely related. Once the pupil dilates, the ability to accommodate for things that are close becomes difficult. Okay, and we call that cycloplegia when we get fuzzy vision and are unable to see things close up. So if we look at scopolamine in terms of its action on the eye and on pupil dilation, we see that it can last anywhere from 3 to 7 days in most patients. Atropine is even longer acting. It can last anywhere from 7 to 10 days, so atropine is very long acting. It's not the kind of drug you'd like to use in your eye exam if you're filling 100 prescriptions a day and you need to read things close up on the screen or on the label of the drug. And so if we go down this column and we look at a drug like homatropine, we see that its duration of action is about twice shorter. It's about half as long as that of scopolamine. Go down even further, see cyclopentolate. Its duration of action is about a day. And tropicamide is the shortest acting of them all, with a duration of effect of about 6 hours. Okay, so I'd like you to look at this table and kind of grasp these concepts without, of course, at least for me, memorizing the usual concentrations. At some point you'll need to know those, but here I'm more interested in having you know the type of drug, its generic name here, whether it's atropine or scopolamine or tropicamide, and whether it is long-acting like atropine or very short-acting compared to the others like tropicamide. If we look at some PK parameters regarding atropine, we see that the drug is readily absorbed. We know it crosses the blood-brain barrier. We know it's metabolized by the liver and excreted primarily into the urine. We know that there are several adverse effects associated with atropine, which many of them are predictable based on its pharmacology. Right? So if we look at the words in yellow, things like dry mouth and blurry vision or sandy eyes due to decreased tear production. Dry eye is another way to say that. Constipation, tachycardia. Those are all some predictable systemic effects of an antimuscarinic. If we were to go down and look at the CNS effects, you can really see things ranging from restlessness and confusion all the way up to delirium. So some CNS effects because of the ability of this drug to cross the blood-brain barrier. Lastly, atropine is contraindicated in people that have paralytic ileus, where the gut is not moving due to perhaps severe trauma, like a surgical procedure or a surgery. And atropine is contraindicated in men with benign prostatic hyperplasia and in patients with glaucoma. So do you remember what contraindicated means? It means it's something that shouldn't be used for. You shouldn't use atropine to treat BPH. You shouldn't use atropine to treat glaucoma or paralytic ileus. And so in fact, contra means against. So against an indication, don't use it for these things in red. And last but not least, in older people, use of atropine may exacerbate a glaucoma attack if the condition is latent. So what do we mean by that? Well, if they're kind of running high on intraocular pressure, but for the most part haven't shown any pathology, right? So they may be high on the normal end, and now this drug is pushing them into a elevated intraocular pressure, which may indeed increase risk of blindness. Scopolamine is one of the most effective anti-motion sickness drugs available. But remember, and we mentioned this briefly a little bit earlier, but only really as a prophylactic treatment, which means prior to the development of motion sickness. Right? So prior to getting on the cruise ship, or prior to getting on the train or getting on the motorcycle, for example. It's not very effective if you already have motion sickness. And again, we believe this is due to effects that are happening in the ear and regulating balance. Scopolamine has an unusual effect of blocking short-term memory, and it's sometimes made use of in anesthetic procedures that are otherwise unpleasant, such as scoping of various types, endoscopy, for example, or colonoscopy, for example. The pharmacokinetics and adverse effects are similar to atropine, although we know that it's a slightly less, slightly shorter acting form compared to atropine. And again, I refer you to the eye, where scopolamine's duration of action is about half that of atropine, which is quite long in the eye. Atropine's effects can last anywhere from 7 to 10 days, so quite a long time frame. Ipratropium is a quaternary derivative of atropine, and it's useful in treating asthma and chronic obstructive pulmonary disease, particularly in patients who are unable to take adrenergic agonists, such as albuterol. Remember, albuterol is a pretty good bronchodilator, but a small percentage of patients won't really be able to take albuterol because of its ability to induce sinus tachycardia in some patients and cause their heart to beat harder and faster. So in a patient that's taking albuterol but having some cardiotoxic effects, it might be prudent to have them switched to a muscarinic blocker like ipratropium. If you look at the structures on this slide, the left being propantheline, the right being glycopyrrolate, these are positively charged drugs used to treat hypermotility states of the gut. And you may predict that their absorption would be quite low systemically, and you would be correct. Right? These are fully positively charged compounds. But when it comes to treating hypermotility of the gut, are you that tremendously concerned about oral bioavailability if really all you need to do is get that drug into the gut? Right? So if all you have to do is get that drug into the gut, then even if you take it by mouth and it's poorly absorbed, where's it going to go? It's going to stay in the gut and end up in the feces, right? So these drugs, they don't have to get into the cell, they just need to crawl up to the surface membrane and block it. Does that make sense? So a drug like propantheline or glycopyrrolate, would you predict a drug like that to have a lot of systemic effects? Or will it mostly function where it's needed? And in this case, the gut. And now compare that to the drug on the next slide. In the upper right corner here, you see dicyclomine. Dicyclomine, as you can see, is a neutral compound. It is well absorbed, in fact, and may have some systemic effects, such as blocking muscarinic receptor in the eye, blocking muscarinic receptor in the bronchi, blocking muscarinic receptor in the heart, and so on. If you look to the upper left, you see pirenzepine, and it's just an interesting drug in terms of it being a muscarinic 1 selective blocker, but again, not used really to treat any diseases at the moment, at least not approved in the U.S. for any particular indication. It is approved in certain countries, certain European countries, and in Japan. So its most interesting element for us is that it's an M1 selective blocker, while these other drugs, all these other ones we're talking about, are just non-selective muscarinic blockers. They block everything, M1, M2, M3. That includes dicyclomine, that includes atropine, that includes scopolamine, that includes tropicamide. Right, you see tropicamide down here below, and again, it's a drug that you're putting in a patient generally through an eye drop, so you're generally putting it where it's needed. You don't predict too much systemic effect, but there's always the case that some may be absorbed systemically, and in some patients, present as antimuscarinic systemic effect. Do you predict that to be highly likely in most patients that get eye drops No, but there will be some patients in which you may see, for example, a tachycardia response, just as an example. If we look at ipratropium here on the left, we see there's a quaternary nitrogen, and this is another drug. It's used through inhalation, gets into the lung, works in the lung, works to prevent bronchoconstriction and to decrease secretions by glands that line the bronchi. But do you predict a lot of systemic effects with a drug like ipratropium? Well, if you look at it, it's positively charged. You're giving it through inhalation. Not too much of it should really be absorbed systemically. So it shouldn't have too many systemic effects when it's given for treatment of a respiratory condition like asthma, compared to a drug that could be absorbed systemically. And if we look over to the right, we see an antimuscarinic drug called benztropine. And benztropine is a neutral compound, right? And so it is absorbable. It is able to cross the blood-brain barrier. It's actually used in the treatment of Parkinson's disease because of its antimuscarinic action. And it's a drug that you most likely will hear about again when you discuss Parkinson's disease in future course. For the moment, we can consider it a much more messy drug compared to ipratropium in terms of potential systemic effects in the ANS due to its antimuscarinic activity. Right, so in the CNS, its antimuscarinic activity is useful for Parkinson's, but in the ANS, we'll get some kind of predictable antimuscarinic effects, like dilated pupil, like speeding up the heart rate, like constipation, prevention of gut motility. I believe that brings us to the end of this slide set. I will keep going if there are more slides, but if this is the last slide, then the next set of slides is going to specifically talk to ganglionic blockers as anticholinergic drugs, not antimuscarinic drugs, but as anticholinergic drugs, as well as skeletal muscle blockers. So, see you in the ganglia in a little while.